I'm speaking to you today from Wurundjeri country, and I'd like to begin these comments by paying my respects to their elders, past, present, and emerging. It seems somewhat counterintuitive against the present bustle of preventative health activities to question scholars' focus on disease and especially lethal pandemics from the long-term perspective of public health history. But today I'd like to suggest that this focus, whatever its goals and achievements, also reinforces several misconceptions and biases deeply lodged within social, anthropological, and historical scholarship on public health. And I hope that clarifying this and bearing this in mind may help design studies and direct questions to address and redress this state of affairs. But above all, as I mentioned, I offer you these observations as food for thought and look forward to our discussion about whether this typifies dynamics in your own fields. So an important development in Black Death studies has been the incorporation of available bioarchaeological methods such as aDNA analysis, about which I was happy to see Sharon DeWitt, a later speaker in this series, is a world-class expert. Here, as elsewhere in medical history, aDNA has helped trace the spread and mutation of plague's causative agent, Yersinia pestis. As you can see here, here, the publications in this subfield appear in prestigious and very visible venues, and rightly so, for they allow us to trace pathogens accurately, leading to new readings of previously known and unknown texts and artifacts. And these are invaluable perspectives, especially when they provide additional tools for reconstructing the disease as a social and cultural phenomenon. Alongside its evident benefits, however, this focus on etiology, epidemiology, and even infectious disease, more broadly construed, can have a somewhat distorting effect for three reasons. First, the allure of mass death often brings with it a tendency to catastrophize on the basis of ambiguous and patchy sources, including aDNA evidence, which is scarce and often very difficult to contextualize. And the counter tendency, that is, to decatastrophize, can similarly lead to essentializations and generalizations that are equally unhelpful for understanding disease cultures and community mobilization in different contexts. This seesawing of rupture and continuity framed in terms of a single event, and that's the main issue, seems very forced to me. And after 2 years of a very synchronic global pandemic, we're all, I think, painfully aware of how intersectional and local experiences can be. Publishers are certainly part of the problem here, driving authors with otherwise very nuanced arguments to come up with titles and keywords that underscore the eventness of the Justinianic plague, the Spanish flu, AIDS, SARS, or indeed COVID. And this is especially true for the Black Death, a term that refers to the onset of the second plague pandemic in Europe and its initial spread between 1346 and 1353. Statistics are very patchy, but this visitation seems to have destroyed somewhere between 30 and 60% of the region's population. And that was only the beginning. As new waves struck different sites and sectors every decade or so for centuries to come, albeit with sometimes radically different consequences. So authors, publishers, and let us not forget, funders have certainly recognized the attraction of the largest peacetime killer in human history. And so just to illustrate this, I did a phrase search in WorldCat last month. And you can see the results yourself before the Black Death. So the phrase, not just the words, the phrase ratchets up to 277. After the Black Death, 804. During the Black Death, 271, whereas before and after the Black Death, and I tried various combinations. So research that tries to straddle, not just compare, but to straddle the event is at a measly 34. So as a snapshot, these stats illustrate the common hypothesis that the Black Death was a major watershed. And we could probably run similar analyses with college course titles, grant applications, documentaries, film, public lectures, and exhibitions. The bottom line is that mass death has a wide appeal and a constant semblance of relevance. So let me anticipate just by saying that part of its appeal to hiring committees, funders, and broad audiences is that it fulfills one of our main expectations about the medieval other, namely hygienic ignorance and apathy. But my main point right now is the danger of foregrounding pandemics, and in this case, a single, albeit lethal bout, for studying the history of public health. Thus, when it comes to the history of public health specifically, that emphasis has exacerbated two equally problematic tendencies among specialists and generalists alike. The first is sort of the glass half empty tendency. From a modernist perspective, the Black Death epitomizes the scientific ignorance and hygienic apathy of pre-modern communities, civilizations, which results in mass death. And by almost the same token, the glass half full or the silver lining view is that the Black Death prompted societies finally to act environmentally and improve hygienic infrastructures, implement quarantine, establish health boards, sanitary cordons, health diplomacy, urban vigilance, et cetera, et cetera. So none of this is to deny that the transformative role of the Black Death in different manners and places. But you see the underlying assumption here, as with the bibliographical numbers I showed you earlier, that the world was more different after the Black Death and that the pace of change really accelerated. Notably, this new hygienic awareness is often being implied without really considering what tools societies had at their disposal beforehand, which is tantamount to making a circular argument about the Black Death as a watershed moment. Let me illustrate this for the sake of the non-medievalists in the house with a more recent example. So if we looked at indicators such as this for face mask usage before the onset of COVID, we could reasonably surmise that their recognized value was marginal outside certain hospital wards and toxic industries. But explosion in popular use hardly suggests general ignorance or apathy. Moreover, looking at US or even Western data suggests ignores other regions and cultures with perhaps other sensibilities and experiences. So to take Japan, whose response to COVID was reportedly very strong, production and import of face masks merely doubled from around 6.5 billion to 13 billion units. And this, once again, is hardly an indicator of apathy in the face of COVID, but rather reflects ongoing use of this popular preventative measure. Nor incidentally, do these numbers mean that Japan is regularly more polluted than the US, or that the US is somehow better zoned than Japan. In other words, instead of seeing upticks in consumption or production in this case, as evidence for prior ignorance or apathy, we should assume, as historians and as anthropologists and as sociologists, and also as medical and public health professionals, that there is a culturally specific understanding of pollution in this case and how to deal with it. So long as we don't work under that assumption, the paradigmatic interpretation, alas, will continue to be calibrated on the basis of Western statistics. And I hope I'm not telling you anything new by that. These examples nod at a third and final issue I want to raise concerning the Black Death's sometimes outsized role in public health history, namely its use as a signpost in Eurocentric narratives of hygienic progress. Ironically, this role is often accentuated by scholars who are in fact open to pre-modern culture's contribution to medical history, even if it was belated and ultimately an inane response to infectious disease. As we've seen, this sort of upbeat, this half-glass full view stresses how the Black Death prompted the development of certain measures, which are now recognized as basic tools in the kit of developed nations. And their preventative healthcare, physical distancing, including sanitary corridors and quarantine, the collection of morbidity and mortality statistics, health diplomacy, and health boards run by centralized governments. Of course, there is much to celebrate and recognize about these measures, especially now after 2 years in which these low-tech measures have saved millions of lives around the globe. But to hitch them specifically to a story of Western hygienic progress requires quite a lot of telescoping and cherry picking, and of course, ignores what came beforehand. For, with isolated exceptions, the measures generally associated with hygienic progress in this vein post-date the Black Death, that is, the onset of the second plague pandemic, by a century or more. So even if mass death operated as a trigger, to continue the metaphor, the gun had quite a lot of defrosting to do before it could fire. That is by no means to suggest that people were apathetic, of course. Rather, their responses drew on a pre-existing prophylactic toolkit developed among different communities that responded to diverse pressures as they understood them from the perspective of the era's dominant medical paradigm, that is, Galenism or humoralism. And before I briefly survey these, let me remind you that Galenism was a system to which Latin Christendom, Western Europe, was a late heir, for it had been studied, developed, and appropriated for many centuries across the Byzantine Empire, among Jewish communities, and of course, throughout Eurasia with the spread of Islam. And here I come sort of to the final section of this presentation. And those of you who've read the proposed text for this session should already be familiar with some of the specifics. So let me summarize the argument before we move to sort of a group discussion. So Galenism, also known as humoralism or Hippocratic medicine, we use them interchangeably, defined human health as a dynamic balance between the four bodily humors on the one hand, and environmental factors and processes on the other. It is thus a highly individualistic science, which sees the human body as complex and plastic, with an important focus on the lived environment and its influences. At the same time, it provides a clear blueprint for preventative healthcare at the group level, with groups sharing common properties shaped through bloodlines, occupational experiences, regions, climates, and stellar movements. There is thus direct as well as intermediate connections between individuals, communities, regions, and planets, all of which the able physician, but also the army general and the urban planner and market inspector need to consider. While much of Galenic medicine focuses on the preservation of balance, it also posits three main ways in which bodies can become imbalanced or ill. Person-to-person transmission of disease, though this should by no means be confused with infection in the biomedical sense. The polluting insight of deteriorated matter, such as rotten carcasses or an unhealthy activity, and most famously, miasma, the pollution of air or water that is then carried and dispersed among entire populations. There were various causes of miasma, from inauspicious stellar constellations to earthquakes, stagnant pools of blood and water, and immoral human behaviors such as blasphemy, gambling, and prostitution. Preparing and responding to such events, keeping environments clean, infrastructures intact, and curbing bad behaviors were part of the same preventative process and anchored in similar medical principles. These involved diverse stakeholders, so not only governments, and seeing them operate in concert, if not always in harmony, helps reconstruct what I've termed pre-modern healthscaping. And this predates the Black Death by a lot. Indeed, the abundant evidence that I and many before me have unearthed, including archaeologists, speaks to pressures that accompanied urbanization rather than the onset of the or a plague pandemic. And that process began, at least in Europe, in the 11th century. It was here that urban communities began devising strategies for the challenges they faced. And it was these techniques that they tended to draw on to resist plague or the Great Mortality, as it was known at the time. And it was these techniques that they tended to draw on to resist plague. As I've shown in a recent article, the earliest and most famous anti-plague regulations issued in Pistoia on the cusp of the plague's arrival to the Tuscan town were no more, but certainly no less, than a reiteration and adaptation of pre-existing measures on burial ceremonies, including religious services, travel restrictions, retail and artisanal practices, especially among butchers, and waste disposal. All these were in place and very much stayed in place with the plague's repeated visitations. So to clarify, I'm not arguing that the Black Death had no or little impact, but neither did the event as such give birth to local public health theory, policy, or practice, as these books, among other numerous other publications, document. They just happen to be nice images of book covers. The journals tend to have less nice covers. As you can see from these, the very same slide, however, much of this recent research, including my own, has focused on Western European cities. But Galenic applications can just as clearly be traced to urban hinterlands and rural sites such as monasteries and mines. And in response to diverse conditions, seasonal and climatic changes, among others. Hellscaping was also practiced by mobile communities as they moved between cities and across the sea and countryside, like pilgrims, courts, merchants, and of course, armies and navies. Tactical manuals have a lot, tactical manuals, for instance, demonstrate how aware army leaders had to be in the location, when they considered the location and layout of army camps from a health perspective. The inventories of merchant vessels, which also took pilgrims regularly, likewise have a lot to say about how people sought to stay healthy in difficult journeys that took them into hostile climates with major demands. And paleopathological studies of sites such as mining cemeteries allow us to see the results of preventative protocols, from diets to protective gears to zoning. It should come as little surprise to you by now that virtually none of these measures stemmed from an encounter with plague, nor were they discarded in its aftermath. Last but not least, environmental approaches to health, which posited an open or plastic body that had to be constantly kept in balance, are hardly limited to Western European populations. Scholars of Islamic cities, armies, and pilgrimage have begun to show this, and I hope to ground their insights further through additional case studies in a new project we're launching later next year on mobile and rural health in pre-modern Europe, the Eastern Mediterranean, and India. So a kind of a Galenic unit, as it were. And the final conference of my current project, the Pre-Modern Healthscaping, Urban Healthscaping Project, will highlight that the quest for a longer history of community prophylactics extends far beyond the boundaries of even Galenic cultures, with contributions from scholars of Buddhist, Vedic, Aztec, and other past medical traditions around the world. So the history of public health can thus be told differently and indeed more accurately outside the strictures of what I call the speed bump view of a medical history focused on infectious disease rather than prophylactic cultures. Thanks for your attention, and I look forward to hearing your thoughts.